Welcome to Top Med Talk. The Society of Cardiovascular Anesthesiologists annual general meeting is coming soon. Check out scahq.org now. More details at the end of the podcast.
Top Med Talk.
Hello and welcome to Perioperative Diabetes Management Nuts and Bolts. My name is Kathryn Kreider. I'm an associate clinical professor at Duke University School of Nursing, and I'm also a nurse practitioner with the Division of Endocrinology, Metabolism, and Nutrition for Duke University Medical Center. My disclosures are listed here. So the objectives of this talk today are to emphasize the importance of perioperative glucose management, describe evidence-based approaches for perioperative glycemic management throughout the perioperative time period, which includes pre-admission, during hospitalization, as well as best practices for discharge. So let's start this discussion with a case study. We're going to talk about a patient named George, and George is very similar to many patients that I see, and we'll talk about his progression through surgery and how we're handling him and making sure that his diabetes is optimally controlled. So George is a 65-year-old male who's referred to orthopedic surgery for a total right hip due to severe osteoarthritis. He reports his daily pain as an 8 out of 10. So obviously that's a situation that he can't sustain long-term, and we really need to try to figure out how to help him as soon as we can. So this is his past medical history. He's had type 2 diabetes for 16 years. He has the other comorbidities that we often see with diabetes and osteoarthritis. Medication list is pertinent for glipizide and metformin. And then when we see him in the perioperative clinic, we notice that his point of care blood sugar is 267 and he has a point of care A1C of 8.8. So obviously we notice right away that his diabetes is suboptimally controlled, and we need to start paying attention to that to figure out how to optimize his care. So originally his surgery was scheduled for about 3 weeks, but then it was postponed indefinitely once his glucose numbers were revealed. So here are the questions about George's care. The first is, what is the ideal A1C level for him prior to surgery? His current A1C is 8.8. We obviously know that's too high. What are we going to do about that? The second is, what is the best approach for glycemic management pre-admission? Then, how should his glucoses be handled during hospitalization? And finally, what are some of the best practices for facilitating discharge in patients like George with diabetes? So let's talk a little bit about the background of this. I don't think anyone listening to this presentation would argue that glycemic management is not important. I think we all know that. We're on board with that. The literature has shown that time and time again. So we know that patients with diabetes have a 45% longer length of stay. Of course, that particular percentage varies based on the study and the population. We know that patients with diabetes have a much higher mortality rate perioperatively. Poor perioperative glucose control has been linked to a variety of adverse outcomes, some of which are listed here. And so this is an area that has really gained traction and attention because we know that patients with diabetes are high risk, and we need to know how to handle this and how to approach it in order to improve their care process. So what additionally is important for us to consider is that there's no clear indication that the relationship of A1C and post-surgical outcomes is clear. In other words, that relationship is a little bit muddy. We don't necessarily know exactly what A1C level someone should be before they come for surgery. And then further, there's really no evidence showing that postponing surgery improves outcomes. And I want to share one study with you that I think might highlight this and help elucidate this issue somewhat. So when we think about surgical outcome studies in patients with diabetes, most of these studies look at hyperglycemia alone or A1C alone. And when they are looked at together, it's usually not in a multivariable analysis where we can actually control for the effect of one of these. And so the question is really, what is the relationship of A1C and perioperative glucose levels with each other with post-op mortality, right? And so there was a study done by some of my colleagues here at Duke University Health System, and it was a retrospective analysis looking at both cardiac and non-cardiac surgeries. And the goal was to determine the association of preoperative A1C with perioperative glucoses. And they defined that as the average of the first 3 days postoperatively. And then they looked at the comparison of those numbers with 30-day mortality in surgery. And this looked at almost 13,000 surgeries over time. And so the first finding was that preoperative A1C actually did a very good job of predicting the average 3-day perioperative glucose level. So you can see here from these curves that these trend and follow very well. So if patients had a high A1C, for example, this also correlated with a high 3-day perioperative average glucose. And this was true for both non-cardiac and cardiac surgeries. When we look into the data a little bit more carefully, we look at, and this slide is looking at postoperative mortality, which was in the first 30 days after surgery. We see that there is a linear relationship between these two, particularly for non-cardiac surgeries. But the interesting thing is that patients who had very low A1Cs actually had higher mortality. And so this also sort of correlates with data that we've seen before looking at patients with hypoglycemia and their potential higher risk for mortality. It's not quite clear what's driving that. It could be that hypoglycemia can impair autonomic function. It can activate white cells. It can cause vasoconstriction. The cytokine release, inflammatory mediators, all of these things could be contributing factors to why hypoglycemia might lead to an increased risk of mortality. When we look at cardiac patients, specifically looking at the average perioperative glucoses, we see the same thing. So patients who had elevated levels of, patients who had blood glucose levels that were on the lower end, so those that had averages of 80, meaning that they actually had quite a few low blood sugars as well, had much higher mortality rates. And you see this U-shaped curve here for these patients. So this is an interesting relationship between these two. So the study concluded that preoperative A1C actually did predict average perioperative glucoses very well, and that average perioperative glucoses was associated clearly with 30-day mortality. And this was true linearly for non-cardiac surgery and then non-linearly as we saw the U-shaped curve in patients with cardiac surgery. So again, being more concerned about patients on the very low end and then on the very high end for having higher mortality rates. The other finding of this study was that after the study investigators controlled for age, BMI, gender, and perioperative glucose, the elevated preoperative A1C was not positively associated with 30-day mortality. So the overall finding is that A1C may be a good identifier for the patients that have higher mortality rates, but perioperative glucose control seems more important. And this actually makes a lot of intuitive sense because an A1C over the last 3 months, that's the average, is just an average, and it's also over a much longer period of time. So it makes more sense that we should be more concerned about perioperative glucose levels. So what are the actual A1C and glucose goals for these patients? So first of all, we need to make sure that A1C is measured before hospitalization whenever possible so that we can gauge how well someone is doing with their glucose management. The American Diabetes Association recommends an A1C goal of less than 7 for most patients with diabetes. Of course, there are caveats to that. And then we also know that perioperative glucoses should remain between 80 and 180 for the duration of the perioperative period. And that is really where we have seen the most benefit to patients by avoiding hypoglycemia and then avoiding glucose above 180 as well. So I want to bring your attention to the fact that A1C does have quite a few limitations. And the reason I'm mentioning this is because I think that some of us fall into the trap of really holding A1C as the absolute marker of whether or not someone can proceed to surgery. We need to understand that A1C, first of all, is just a 90-day average of glucose. It doesn't share any information about glucose variability. There's no information about frequency of hypo or hyperglycemia. And there is more and more data coming out about A1C inaccuracy. So any condition that can affect the red blood cell health or lifespan will affect the A1C level, causing either falsely low or falsely high readings. And so not that anyone is expected to be an expert on that particular issue, but it does help us understand that it should not be the only thing that we're looking at when we're trying to establish someone's glycemic control. One thing that we're using more and more in endocrinology and diabetes is the idea of continuous glucose monitoring. This actually, what I believe, will end up being the gold standard for glucose measurement. And these are devices that measure interstitial glucose every 1 to 5 minutes, depending on the device that's used. The patient inserts it It's worn for up to 14 days, depending on the device, and it will provide feedback and alarms in many cases so that patients can make adjustments to eating, or they can take correction insulin, or they can go for a walk, or whatever it might take to actually improve their glucose. And these devices have been shown to improve glucose control, reduce glucose variability, and perhaps most importantly, reduce hypoglycemia. When we're thinking about inpatient use, they're currently not FDA approved for inpatient use, but they are used in many institutions with certain protocols. And they're really a great tool, not only for patients, but potentially for staff as well, to decrease the number of finger sticks, et cetera. So this is something to keep an eye out, as I believe it will continue to increase in popularity in the hospital setting. And then clinics can actually use a professional or a diagnostic device. So if we don't actually want to prescribe this for a patient, or if they don't qualify or can't afford it, we can prescribe a short-term diagnostic device in order to really elucidate what's going on with their glucoses at home. Let's talk briefly about medication management. We do know that insulin is the preferred method of glucose management for patients, especially when we're thinking about rapid lowering of glucose levels. So there are lots of other options for diabetes management. GLP-1 receptor agonists, SGLT2s are very commonly used, but they have more side effects. They take potentially longer to achieve better glucose levels. And so insulin is really ideal for many of these patients who are looking for surgery and who are hoping to plan their surgery, because we know that their response will be predictable for the most part. It's also the safest to use and titrate in the hospital. So for maximum efficacy, what I do recommend is using weight-based doses. And this is based on literature. We do know that we can start patients on, for example, 10 units of basal insulin and have them titrate up. But I strongly recommend, and many of my endocrinology colleagues would recommend, starting with weight-based dosing, because you're going to get to goal sooner and more quickly and have a more efficacious dose right off the bat. And so the recommendations for weight-based dosing are listed here. I won't read through those. But if you have staff that works with these patients that tries to tee them up for surgery, I highly recommend that you look at the weight-based dosing recommendations. Other common diabetes medications. So again, I mentioned insulin would be preferred for many patients if we're trying to tee them up quickly for surgery. Most of the other medications have at least some cons to using in the hospital setting. There is highlighting on SGLT2 inhibitors and GLP-1 receptor agonists, because many of the medications in these classes have FDA indications for cardiovascular risk reduction. That is fantastic. And that basically means we should try to use these medicines whenever we can, and try to use them in conjunction to optimize diabetes management. So the problem is, though, that when we're thinking about hospitalization and perioperative glucose management, there are definitely some reasons that we need to use caution. And so I'm not going to read through this chart, but just know that we have to be thoughtful about the medications that someone is on. And if we know that they are going to end up being in the hospital, we need to think about adjusting their medication. So the other thing that I think advanced practice providers, PAs, and nurse practitioners do really well is to incorporate patient education. And this does not have to be laborious. This can be fairly straightforward and not take a lot of time. But when patients come to our clinic and they're trying to be scheduled for surgery, this has to be part of the conversation, because a lot of times their diets are not optimal and they really need some help in that way. So these are the three things to talk about. First of all, limiting carbohydrates, especially simple carbs, juice, soda, lemonade, sweet tea, etc. Anything with regular sugar. Then limiting sweets, desserts, etc. And then talking about potatoes, fries, things that are not a lot of nutritional content that have a high carbohydrate load. The second is that patients need to start some sort of home blood glucose monitoring, either with a traditional finger prick or with a continuous glucose monitor. We have to be able to measure short-term outcomes. We can't necessarily wait until their 3-month A1C is due. We need to be making more headway quickly. And so it's essential that we have that data to make those decisions. Finally, we need to be educating patients how to titrate their insulin or their other medications at home. So if you start someone on basal insulin, for example, you need to teach them how to titrate for example, by 2 units every 3 days until they reach their goal fasting glucose. And so in that way, we can make more quick, more rapid progress to what our goals are. Here are a couple of medication considerations prior to admission. First of all, so many patients are on metformin. Metformin should always be held on the day of surgery. If a patient is on an SGLT2 inhibitor, they should be held 3 to 4 days before surgery because of the potential for dehydration as well as euglycemic diabetic ketoacidosis. Then we should withhold other oral antihyperglycemics on the morning of surgery. That's sort of easy to remember because the patient is not eating, right? And so that if they're not eating that morning, then we know we should be holding their morning medicines. And then if there's someone who's on basal insulin, we should be giving about 80% of that dose, either the morning of or the night before, depending on when they're taking it. The reason we cut that dose back is because a lot of patients are on insulin that actually is sort of covering their food intake. And so we call that over-basalization, but in order to be safe with that, we want to slightly reduce their basal insulin to avoid hypoglycemia. Finally, there's no data on GLP-1 receptor analogs on glycemia perioperatively. A lot of these medications are given once a week, and so the patient might have it on board when they come in for surgery. Totally fine, but it is something to be aware of if they started having GI issues. There are a lot of publications that go over what to do with insulin, for example, or what to do with oral medications. This is just an example from Pierres and colleagues. And it's actually a quite simplified version of how you would handle the different types of insulin and oral medications. But if you have a perioperative glucose management process, it would be helpful to have something like this that your colleagues, providers can reference so that they can make sure that they're giving out consistent information to patients. All right, so let's go back to our case study with George. So we know that George has an elevated A1C. He's on some oral diabetes medications. So what did we do with him when he came to see endocrinology? So he was referred to endocrine to optimize his diabetes before surgery. So we placed a professional CGM, continuous glucose monitor. We added basal insulin at weight-based dosing, 0.2 units per kilo per day. So he's 100 kilos. He's going to take 20 units to start. And then we added semaglutide at the lowest dose, which is 0.25 a week. And then we also did dietary counseling. So these are a lot of things we did at once. These are probably more things than I would do if I saw him and he was not pending surgery. So usually I try not to overwhelm patients. We certainly want them to get to goal, but this is a fairly aggressive approach because we know that this gentleman is in a lot of pain and he needs to have surgery as soon as we can get him optimized. So George he does those changes. He comes back to clinic 2 weeks later. His CGM download shows that his blood glucoses have improved. His average now is 195. So we further intensified his diet, carbohydrate restrictions. 3 weeks after that, he comes back. His glucoses have dropped an average of 30 points down to 165. At that point, we increased his semaglutide to 0.5 milligrams per week. When he comes back in a few weeks later, he now has an average blood glucose of 130, which is tremendous, right? It's exactly where we want him to be. His estimated A1C based on his average glucose is 130. So this is a perfect example of intensifying a regimen quickly, getting someone to goal, and optimizing their care before surgery. So George is admitted. So what do we do now? So he's in the hospital. We know that inpatient glycemic goals should be 140 to 180 for the majority of critically ill and non-critically ill patients. So 140 to 180 while they're in the hospital. If someone is having cardiac surgery, if they have the preference of the surgeon, if they have another reason that they could potentially achieve more stringent goals of 110 to 140, that can be considered for certain patients, but they should not have any hypoglycemia. So we can't intensify someone to the point they're having lows because we know that that is dangerous and that causes additional hospitalization issues. So the goal for many is 140 to 180. You can consider a slightly more stringent target, but absolutely blood glucose is less than 70 should be avoided. So when he's admitted, his arrival blood glucose is 125, which is excellent. He did follow the instructions as far as holding his oral diabetes medications and taking 80% of his basal insulin. His blood glucoses during surgery stayed between 90 and 130. And then he does really well until he starts to eat. Okay. So then at the point where patients begin to eat, then we have to think about what to do next. And so what I strongly recommend, which is also supported by the literature, is to start prandial insulin. So give someone a amount of insulin that they should take in the hospital when they start to eat. You can also give additional instructions about holding the insulin if they're not eating, or giving half dose if they're taking half of their meal, etc. But we will always be chasing blood glucoses if you only give someone correction insulin. So they should really have a prescribed dose to take with meals. And that's what happened with George. He was given weight-based insulin. So he was prescribed 10 units with meals and 20 units of his daily degludec, which was the same as his home amount. And then his blood glucoses remained less than 180 throughout the duration of hospitalization. So he did great. So discharge planning, just a couple of things to think about. If someone has excellent glucoses before they're admitted to the hospital like he did, then for the most part, we can really send them home on the same regimen. We just have to think about changes in health that have maybe occurred during hospitalization, changes in glucoses, changes in medications, and then of course, changes in renal function. That's a really important one. We want to ensure patients understand their medicines, they have access to them. That's especially true if they're started with a new medication in the hospital. And then if someone's diabetes medications are changed, then we should see them in the outpatient clinic within 1 to 2 weeks, ideally. If they have not had any changes to their preoperative diabetes medications, within 4 weeks is a reasonable approach. So just keep in mind, they really need to have follow-up. So let's talk briefly about what we are doing preoperatively at Duke to improve glycemic control of high-risk patients. So we have what we call the POET diabetes program. And this is an arm of the larger POET program. And we call it POET, which is Perioperative Enhancement Team. And the goal is to optimize health before surgery in order to improve outcomes after surgery. And so with regards to diabetes management, we're really trying to identify patients with uncontrolled diabetes or high risk of hyperglycemia as far in advance of surgery as possible. And so we're really trying to create this whole picture of improved health and improved status before we even attempt any operations. So this is a very simplified algorithm of how we handle these patients. And so patients who have pre-existing diabetes should always have an A1C if they have not had one in the previous 3 months. For patients who are high risk, they should also have A1Cs. And the high risk criteria is pulled directly from the American Diabetes Association. And so these are the patients that we check A1Cs on that do not already have diagnosed diabetes. I'm not going to read these off to you, but I want to point out one thing. And that is patients with a BMI of over 25 who are also over 40. And so that's quite a few of our patients, right? And so keep in mind that probably many, if not most of your patients that are being operated on will need to have an A1C checked before they go in. So this is what we do. If someone has an A1C over 7.5, then they need to see endocrinology. We can refer them and get them in quickly to our endocrine clinics, or they can certainly see an endocrinologist outside of Duke if they prefer that. Sometimes the wait time might be too long. So that's why a lot of patients opt to go through our program, because we have a pathway of getting them seen soon. If patients have an A1C less than 7.5, at that point, they are cleared for surgery. So as far as the endocrinology referral, if the patient agrees, we have actually a pre-existing POET referral button in Epic, and they receive an expedited appointment. So we try to see them within a week, within 2 weeks at the most. And sometimes this happens sooner or a little bit later, depending on the situation, but we do try to get them in soon. We have certain providers that have POET slots that patients are put into, and those are saved for those patients. And then the endocrine provider communicates with the surgeon. So I will also point out that this is staffed heavily by our APPs, nurse practitioners and PAs. They are an excellent resource for this. They have enjoyed it. It's really rewarding to see patients make progress so quickly. And so that is an excellent resource for your programs if you're thinking about implementing something similar. If the patient decides that they do not want to see an endocrinologist, they are welcome to see their primary care provider. And then the patient then is responsible for notifying the surgeons when they have more optimal glucose control. Of course, that has to be verified with their clinic. So, we don't make them do anything, of course, but these are the options that they have in order to really try to get them to goal as quickly as we can. I want to point out a couple of outcomes that were published by one of my colleagues. Dr. Tracy Secchi is going to be on the panel when we discuss this in September during the EBPOM program. But this is a study that she and her colleagues published from our Duke data. This was a relatively small study, so there was only 60 participants, 30 in each arm. And so that led to really a lack of statistical significance on a lot of these outcomes. But I want to show a couple of them to you because I think that this highlights the importance of this. And I believe it shows that if we have a larger study showing more of these patients, that it would be statistically significant. So a couple of examples. The first is that for patients who went through this diabetes pathway, when they came in for surgery, their fasting day of surgery glucose was 131 for patients who went through our program. Patients who did not, who were in the matched controlled, had a glucose of 168. So I think we would all agree that that is very clinically significant. It is not statistically significant because of the numbers. The second is that the median postoperative glucose for our diabetes pathway patients was 155. For those in the matched control group, it was 174. So again, that's an example of a clinically significant difference. When we look down at hypoglycemia, there was no difference. Patients who went through the diabetes pathway, 4 of them were on insulin and none of them were for matched controls. There was no difference in length of stay or readmission, interestingly. The next thing that's actually interesting, though, is that patients who went through the diabetes pathway, 83% of them went home or to self-care, which is arguably the same thing. Whereas only 50% of the matched control patients went home for self-care. That's a huge difference. And this was one of the areas where we saw statistically significant differences in the groups. Only 10% of the patients in the diabetes pathway went to a skilled nursing facility and 33 did for the matched control. So this is important. This contributes to burden of care, cost of care, et cetera. And I think this is an area that will continue to have more and more data. This particular study was just published in 2021, so we will see more and more data as we collect more over time. So in general, I just want to say that the typical experience that I have with these patients is that we have a new patient consult, we make lots of medication adjustments, we do patient education, we have a plan for glucose monitoring. Typically, I like to see these patients in 2 weeks, no more than 4 weeks. And so we're following all of these things. We're making sure that someone's making progress. The patient is responsible for being in touch with us if the recommendations don't seem to be working. At the bare minimum, they're going to get a follow-up A1C in 3 months, but we really hope to see some changes quickly and to continue making changes in several week increments. So surgeries can be scheduled at any time with the approval of the surgeon and team. And so what I tend to do is communicate often every time I see a patient about the progress someone is making. And the bonus for us is that patients are very highly motivated to improve. And a lot of times that's because of pain and they want to get their surgery done. And so they are willing to make these changes and they do them quickly, which is an excellent outcome. So in summary, perioperative glucose levels are likely more important than A1C in patient outcomes. Patients should maintain perioperative glucose levels 80 to 180, and I would argue with the support of the data that the perioperative glucose levels are more important than the A1C. Insulin is the safest and most predictable therapy to use perioperatively, and please remember to use weight-based dosing whenever possible. And then perioperative glucose enhancement programs, similar to the one that I just discussed with you that we have here at Duke, have been shown to contribute to improved glycemic control and outcomes. So I would encourage you, if you do not have something similar, that this is an excellent opportunity to improve your care pathways, to help improve patient outcomes, and really to optimize care throughout the continuum of the perioperative period. Thank you very much.
Top Med Talk.
The Society of Cardiovascular Anesthesiologists' 44th annual meeting is coming soon, and Top Med Talk will be there. If you want to pop along and see us, it's on May the 14th to the 17th in Palm Springs, California. Check out scahq.org now for special offers and more details. Also, if you're not sure if you can make it in person, why not explore the virtual track? Innovation during COVID-19 now means more than 60% of this year's sessions will also be fully available for you online. Check out scahq.org. That's scahq.org.